We now introduce our very first speaker of our program, Dr. Mira Wagh. Dr. Mira is known for her gentle demeanor and witty approach. She has been an integral part of the Thoracic and Gastrointestinal Services as an associate professor at RCC Trivandrum. We welcome Dr. Mira to speak on MSI testing, indications and implications.
A very good morning to all. For the benefit of postgraduates, let me begin with the basics of genetics of what is MSI, what is MMR, and then go to the topic. What are microsatellites? They are 1 to 6 base pairs in repetitive sequences. These are normally present in cells. When a DNA replicates, some errors can happen, and it is the job of DNA polymerase to rectify these errors. But then, when there are repetitive sequences, everything is looking similar. The DNA polymerase might sometimes fail, and it slips at the areas of repetitive sequences. In that case, we need a more robust system, and this system is the MMR system. That is a mismatch repair system. So in human beings, this system has different genes coding for different proteins like the MSH2, MLH1, PMS2, MSH6, and EpCAM. And these proteins coded by respective genes exist as heterodimers. 3 heterodimers, MSH2, MSH6, MSH2, MSH3, MLH1, and PMS3. And there can be epigenetic changes also, which can affect this MMR system. So when it comes to laboratory testing, to test for these proteins, there are antibodies against 2 of these heterodimers, which I have marked. There are antibodies against MSH2, MSH6, and MLH1, PMS2 heterodimers. So when we look at these heterodimers, each heterodimer will have a stable component and an unstable component. So the first heterodimer, MSH2 is the stable one, MSH6 is the unstable one. Likewise, in the second one, MLH1 is stable, and PMS2 is always unstable. So what happens? If one of the gene is affected and it is not coding for the respective protein, say if MSH2 is not there. Now the second one, which is remaining, is unstable. It cannot exist without MSH2 and it will get degraded. In that case, the immunase stain will be negative. But however, if the unstable gene, it is not, there is a defect in the unstable gene, it is not coding for the protein will not get expressed, but the stable one can still survive, and there will still be some staining. So what we mean by MMR deficient, when the result of MMR test, that is IHC, comes, is that there is loss of protein, there is no staining. But MMR can be proficient if the entire heterodimer is intact, or there is loss of the unstable protein of the heterodimer, and 5 to 10% can regain antigenicity, though they are not functional. So what is MSI? MSI is done by molecular tests, by PCR or next generation sequencing. It's the actual translation of the defect in a gene into instability of macrosatellites. It is the epiphenomenon of MMR. Coming to indications of MSI testing. Now MSI testing is the only biomarker in colorectal cancer which has diagnostic, prognostic, as well as predictive role. It can predict response to immunotherapy and 5-fluorouracil chemotherapy. It is the hallmark of Lynch syndrome, that is germline, not the somatic mutation, germline mutation. If it is positive for MSI, it is Lynch syndrome. However, 20% of deficient MMR or MSI high are only 20% are Lynch related. Now what happens? If there is a defect in MSH6 and PMS2, these patients will still have Lynch, but they tend to develop later in life, and metastases are more likely. Coming to the prognostic role of MSI, it's in general good prognostic. Only 4% will present in stage 4, and when they present in stage 4, they generally behave badly unless they are treated with immunotherapy. Why is this so? Because in this 4% of the cases, usually there are other mutations like P53, KRAS and all, which will alter the biology. Predictive role, generally patients who are having MSI high will not be responsive to 5-FU. So the role comes in stage 2 colon cancers when where there is no indication of giving 5-FU if the patient is MSI high. Coming to immunotherapy, MSI high also indicates that the patient might benefit from immunotherapy. So how do we select patients for MSI testing? There was this Amsterdam criteria, not for selecting patients for MSI testing, but for selection of patients for research on HNPCC. The true negative value of this Amsterdam criteria is high. However, the sensitivity is very less. The Bethesda guidelines, revised Bethesda guidelines, are used as indications for MSI or MMR testing, not MSI alone. It's always MSI testing bar MMR testing, and they do not specify whether it is germline testing or somatics testing. Just to summarize the Bethesda criteria, to make it easy for postgraduate, less than 50 years, if a patient or first degree relative or second degree relative has an HNPCC related cancer, go ahead with MSI testing. Less than 60 years, if he has MSI histology, I'll come to what MSI histology is. And irrespective of age, if the patient has a synchronous or metachronous cancer, or 2 or more first or second degree relatives with cancer. MSI histology, presence of tumor infiltrating lymphocytes, Crohn's-like lymphocytic reaction, mucinous signet ring cell differentiation, or medullary growth pattern. The sensitivity of the revised Bethesda is better compared to the Amsterdam criteria. Specificity is a bit less. Now we have another guidelines called the Mallorca guidelines from Europe, where they say that you should do MSI testing for all colorectal cancer. Probably the purpose is to correctly identify patients who have Lynch syndrome. But for identification of, as I said earlier, for identification of Lynch, we need to have a germline test, not the tumor test alone, because if the tumor is MSI positive, it can be because of sporadic reasons also. But in real practice, MSI is not used as sufficiently as a biomarker for sending patients for germline testing in Lynch syndrome. All these criteria misses 50% of those affected and those who are carriers, especially the MSH6 and PMS2, which are the unstable of the heterodimers. So germline testing indications, I talked about somatic and germline together. Now coming to germline. If the tumor is high in MSI, it's used to diagnose Lynch. It can be used for patients in whom tumor is not available and he is suspected to belong to a Lynch family syndrome, or an unaffected relative who wants to undergo this testing. Is it mandatory? Can we mandate a patient to undergo germline testing for MSI? Suppose the somatic test comes positive for MSI and we think that we want to accurately diagnose whether it belongs to Lynch family. Can we make it compulsory for patients? Probably no, because genetic testing cannot be done without counseling. And there is a limitation to counseling centers. There is uneven distribution, may not be available everywhere. Patient himself might deny undergoing a genetic testing for various social reasons. We need an informed consent from the patient. Coming to social things, there might be a fear in patients that there may be discrimination at workplace. There are provisions in the court of law against it, but still this fear exists. Insurance, whether the insurance will pay for the treatment of patients if tested genetic, that is again another issue. There are provisions in the US law and also in the Indian law which mandates that insurance companies have to pay for any patient who is born with a congenital defect. It does not say about cancer, but it does say about congenital defects or congenital genetic disorders. Germline testing can be used for referral of a patient to a hereditary or to a dedicated hereditary and genetic disease center. In India, again, that is questionable. Not many are available. It can have implications on surveillance for colorectal cancer and other Lynch-associated tumors. But if a patient tests negative for MSI histology, and if he has many of family members who are developing these kind of cancers, will we deny surveillance or will we not advise surveillance? Again, questionable. We will probably advise surveillance for them. And to find out the accurate prevalence of Lynch syndrome in the society. PCR or next generation, PCR, usually 5 microsatellites are looked into. Next generation sequencing, we can look at a lot of microsatellites and lot of thousands of genes can be assessed at the same time. We can look at other mutations also which can be affecting the manifestation of Lynch. And we can also have Lynch syndrome patients which can be microsatellite stable or microsatellite indeterminate. And there are tests coming up which may be more sensitive than this mutational analysis called multiple instance learning tool and all. They're just coming up in literature. So how will the diagnosis of MSI help us? May probably to determine what type of surgery we should do. There is higher strength of recommendation to suggest a total colectomy with ileorectal anastomosis in a patient who is MSI high for Lynch syndrome. Lesser surgeries can be considered for patients who are elderly or who are having comorbidities. Generally, a patient with Lynch coming with without any colorectal cancer will be advised colon surgery. Generally, it is not done. The diagnosis of MSI also helps us to suggest screening and surveillance. Screening of family members in a Lynch family usually starts at 20 to 25 years, every 1 to 2 years. Age usually 2 to 5 years younger than the youngest colorectal cancer in the family. If it is MSH6 or PMS2, screening can start a little later also. We can also advise lifestyle modifications, diet, physical activity, aspirin and all to patients who are having MSI high in family. So coming to predictive role of MSI high, as I said, it can predict the response to chemotherapy. Stage 2 colon cancers, usually MSI high patients will not be responsive to 5-fluorouracil. So usually it's not recommended to give chemotherapy for a patient with stage 2 colon cancer if he tests positive for MSI. Coming to immunotherapy, how immunotherapy acts. The different tumor mutations produce a lot of neoantigens, and the body will produce an immune response against these neoantigens. The PDL, but the tumor again will try to combat this, and it will upregulate the PDL1 and PDL2 inhibitors, which block the PDL receptors on T cells. So if we can inhibit this PDL receptors, if we can block this PDL, then probably T cells can act against the tumor and our immunotherapy will work. Okay. So immunotherapy generally recommended in stage 4 colon cancers, colorectal cancers. Stage 3, there is an upcoming role in neoadjuvant and adjuvant setting. It seems to be quite promising. There have been reports where the tumor has completely disappeared with immunotherapy. Immunotherapy and chemotherapy can be used together also in neoadjuvant and adjuvant, but there are no guidelines as such. There is no high level of evidence. Phase 2 studies and all have been done, and I think evidence will come up in very near future. So to conclude, what are the indications of MSI? Most of the guidelines just talk about MMR and MSI together. Nobody says whether we should do MSI alone. Probably the only real indication of doing MSI test is one, to find out prevalence of Lynch in the society, but we cannot compel a patient to undergo MSI testing. Second thing, predictive role in immunotherapy and for chemotherapy.
Thank you, Mira. I think the topic is open for discussion.
Thank you, ma'am, for your enlightening talk.
Mira, may I ask a question? Now, I think you have presented a lot of theory, and there is ample evidence to see that this test should be done at the outset. But really, practically, when we have a patient which is at your doorstep, a young patient, you have to, will you order for the test, or are you okay with the immunohistochemistry, which may be showing this thing in the perspective of the treatment outcome of the particular patient? And I know that your American guidelines are arguing for it. Are Indian guidelines arguing for doing universal testing for a patient at your doorstep?
No, sir, but I will definitely advise the patient that this option is there, and if they want, they can. There are a lot of social issues. Somebody might feel that, okay, my child, if he is tested positive.
I'm not taking the family. The genetic testing for the patient for improving the outcome.
I will definitely advise, but it is up to the patient whether to undergo.
Rama, would you like to chip in? What is your opinion? And what is the cost implication also? Because Rama is an expert in the colonic genetic.
I'm not an expert in colonic genetics anyway. So we did universal testing for 3 years at the Cancer Institute. Overall loss of expression rate was only around 23%. In rectal cancer, it was around 4.2%. And it costs roughly around 5,000 rupees to do the IHC if you're doing it for everybody. So we thought that it was probably not cost effective to do universal screening, although it is recommended by ASCO and NCCN. So we are now restricting it to select situations in a non-metastatic setting. In metastatic setting, we prefer to do IHC, but in a non-metastatic setting, we do it only in select cases. In stage 2 colon cancers, and in anyone with the revised Bethesda guidelines whom we suspect to have Lynch syndrome. Otherwise, we don't prefer to do universal testing.
So why do you want to do it in stage 2 colon cancers?
Stage 2 because the medical oncologists want that to determine whether to give adjuvant chemotherapy or not. That is the only reason why.
But how long it will take for the result to come if you order a genetic test?
Within a week, we'll get it.
Okay, that's fine.
Stage 2 colon cancer, I don't know whether medical oncologist is there in the crowd or not. Stage 2 colon cancer, we decide based on adjuvant therapy, based whether the patient is high risk, intermediate, low risk. High risk goes for chemotherapy, single agent at least. The intermediate risk group, that's what I find the medical oncologists doing it. They do the MSI testing and the results is available in 1 week's time. So if it is high, they don't give you chemotherapy, even if the high risk pathological factors.
The only thing I want to identify what's the time, weightage time for it. If it is a month, you should not do it.
It's IHC is just about one week.
One week. But the genetic test will take time, I think.
That will take time, but I don't think there is any urgency in doing it.
IHC is okay with you.
Yeah, for these purposes, IHC is enough.
Okay, so you don't want
That is that is the preliminary step towards determining whether a germline mutation is required or
And in a resource intensive setting, once you get IHC positive, will you still order genetic testing or are you happy with the IHC testing?
It depends on what you are asking for.
Index patient, only index patients.
If you're suspecting a Lynch syndrome, you would, based on the IHC, I will be talking about that in my lecture.
Thank you.